Good evening, welcome. I'm Adele Gauthier from Breast Cancer Foundation New Zealand, and tonight we're talking about how to manage fear of cancer recurrence. Before we get started, some housekeeping. If you have any technical issues, you can type details of your problem in the chat box at the bottom left of your screen, and our support team will be in touch. Or call the number you see there and enter the passcode to get help. If you have any sound problems, you might prefer to listen on your phone while watching on your computer. You can see some instructions as to how to do that at the bottom of your screen. You can use the chat box during the webinar to submit questions, which we'll get to later, and you can also chat to other people there. Don't worry about missing out on information while you're chatting. The webinar is being recorded and will be available on our website in a few days. So, tonight we're talking about how to manage the fear of breast cancer recurrence. We have three panelists who are going to share with you. A patient, Carly, oncologist, Dr. McCrystal, and Dr. Geraldine, Tennant, a health psychologist. First, we're going to hear from Carly. She was diagnosed with breast cancer earlier this year at age 40. Carly, thank you so much for being here tonight. You've only just finished treatment, but I know you're well aware of the fear of recurrence. So tell us where you're at.
Wonderful. Okay, well, thank you very much, Adele, and to the Breast Cancer Foundation for hosting such an amazing event and a series of webinars, which I think are a fabulous resource. Thank you very much. I feel both very grateful to be here and involved in this webinar, but also another feeling that I have is a high degree of anxiety and vulnerability in coming to talk about what would have to be one of my greatest fears, which is, of course, that that breast cancer could return and could impact my life and the life of my family further. So I'm going to take a little bit of a silver lining approach to it, and if I do survive tonight's webinar presenting to hundreds of people on my greatest fear, we'll put that down to another experience that breast cancer has given me. It's been new this year. What I'm going to do tonight is talk through sort of three areas and then pass you on to the experts here who will talk more eloquently than me, I'm sure. But I wanted to talk first of all a little bit about my own background and the treatment that I've undergone through the course of this year. I then wanted to touch on some of the feelings and thoughts that have been, on my mind over the sort of last 6 months in particular, and as I sort of start to move on from the direct treatment period. And then how I'm aspiring effectively to approach things, and I sort of use the term aspiring because sometimes I'm successful and sometimes I'm not. I think that's part of the process. So I'm going to start with just a really brief overview of my personal situation. As Adele said, I was diagnosed earlier this year with stage 3 lobular breast cancer, and through the course of this year I've undergone surgery and preventative chemotherapy and radiation. I've also started chemical menopause and taking hormone therapy to reduce my future risk of breast cancer recurrence. So you can see a little bit more detail of that on the slides, I think, in front of you. I won't talk through any of that in detail, but I did just want to highlight that rather ironically, post agreeing to do this particular webinar, but before tonight, I did find a lump in recently. So I've had a live case and recent scare of what recurrence could be like. I'm extremely grateful to be in a position that it's not recurrence after going through scans and biopsy, but certainly, as any of you will know, this experience is that period between when you find something or you suspect something, and that waiting of results is a very, very challenging time. And so literally last week, the biopsy results confirmed that there was no issue there and it was fat necrosis, but it certainly makes for a webinar like this to be particularly relevant for me in thinking about how I move forward. So the next slide is just sort of some of the feelings, I guess, and thoughts that I personally associate with the sort of fear of recurrence. I'm sure that every patient has a very big and wide range of different experiences and thoughts and feelings in relation to it. So some of these may resonate and some of them not. And I think the main thing is just acknowledging that actually whatever thoughts or feelings you do have are okay and are perfectly understandable and reasonable. Touching really briefly on them, that uncertain, not being able to say with certainty that you are out of the woods or cancer-free or all clear in the breast cancer space is obviously a very challenging concept to understand and deal with. I think there's a high degree of feeling overwhelmed. It's certainly been my experience in relation to the cumulative impact and build-up of treatment over time. And once you get through that immediate treatment period, what comes next, and the choices that you have available to manage your own treatment do seem very significant. You also get a lot of advice, and it's hard sometimes to know what the right thing to do is. I think the fear that every little ache and pain that you might experience is some sort of recurrence is a very common one, and one that I've experienced on things that very very rationally I know are exactly the same thing that the entire family has had that week. But your subconscious plays on your mind around what that cough might be or that ache or pain might be. And so, managing your anxiety in times like that is challenging. Opinions of others, I think, have featured heavily and will continue to feature heavily in my mental journey around fear of recurrence. Whether people feel that you've finished the treatment, so you've finished and everything's fine, or are seeking to know how you're tracking your progress and have you got the all clear yet is often a question that I get. And also a wide range of advice from anyone and everyone on whether they may have had experience or not, which is all very well intended, but if you're in a low point, can be sometimes hard to manage. A bit of a sense of grief and loss about that carefree period in your life you may have lost, which you didn't realise you had until you no longer had it. And of course, with everything changing, your physical and your capabilities, your endurance, spiritually stuff might change. Definitely for me, there's been a change, a question of with so much change, what's left? Who am I that's left behind? So I'm going to now sort of, move on to a bit more of a positive note, whilst acknowledging that, these feelings are, I just want to make sure that that I express that I feel that these feelings are absolutely okay and permissible and right for people to have. And as I move forward to talk about my approach in dealing with some of them, would like to stress that my approach here is it sounds very positive and idealistic and optimistic. It's certainly, for me, aspirational. Some days I'm fantastic at living what I would aspire to do and going forward, and some days I'm not. And I frequently fail in my own, approach. But the idea is to have something that I can look to as a guide to move myself forward. My personal philosophy is really based on the fact that although I can't control the situation, I most certainly can choose to create lots of space between what's happened and how I respond and how I'm choosing to live my life, whatever that life turns out to be. So my sort of principles, if you like, are that acceptance of that situation is important, and also that being open and sharing how I'm feeling, my emotions, being honest with myself, but also with those around me, so that indeed those around me are able to, go along on the journey with me. Owning my own health and well-being, I think that you're the only person that, you're the only one that has the opportunity to do so. And there's lots of choices out there. So on the screen you can see some of the choices that I've specifically made and aspirations that I have around the amount of regular exercise I get, the amount of working hard to support myself mentally and, if you like, a little bit spiritually, as well as in the more traditional health areas. and a very big role of food and consciously being nutritious in my choices is sort of key tenets of my own approach. I think it's very important to be open to learning in this area and open to new ideas and new studies that might come through, different perspectives that might be useful in your own journey. And being both informed and intuitive might sound a little bit contradictory, but in fact I think it's possible to be quite specific about how you research your facts and seeking advice and guidance from experts, but also trusting your gut and your instinct about the best course of action. And then I think the most important thing is, for me, is setting some parameters in place, or has been for me so far, setting some parameters in place that allows me to live my life and not be looking over my shoulder and second guessing continually. I just intuitively feel that looking back or trying to put my finger on why this has happened to me is of no personal use. And so my whole aspiration is to try and look forward. Again, I would just like to say that I'm only successful on that sometimes, and I'm sure that there'll be times when I do better at that over my life going forward, and times that I struggle and seek help for that. My last slide I just wanted to end on is some quotes that have helped me. I've done a lot of reading and reflecting and talking with others, including these two people at this panel, somewhat coincidentally. But there's just three quotes that I've put up on the slide that have been ones that have particularly talked to me and helped me during this what is really early days in the breast cancer experience for me. One is just, I guess, an acknowledgement around the fear and facing one's fear and working through that process, that there is a silver lining in there and it allows you to get potentially closer to the truth. The second one is kind of what I've kind of touched on is really trying to take space between, the stimulus and how you respond. That's from Frankel, who survived the Nazi labour camps, and the harshest suffering, found freedom through that thought process. And the last one is from a philosopher, Eckhart Tolle, which I think is really relevant. Life will give you whatever experience is most helpful for the evolution of your consciousness. How do you know it's the experience you need? Well, because it's the experience you're having at the moment. So that's all I've got. I just wanted to take the opportunity to say a very big thank you again to the Foundation and to all of the healthcare professionals involved in the breast cancer prevention and treatment areas. From a patient's perspective, I don't get often to thank so many people all at once, but the passion and the care and the commitment that goes in is very, very valued. And thank you.
That's great. Thank you, Carly. That was absolutely fantastic, and I'm sure really inspiring for you guys at home. Thank you. Now we're going to hear from Dr. Mike McCrystal. He's an oncologist specialising in breast and melanoma and skin cancers at Auckland Hospital and also at Canopy Cancer Care. Mike, how do you talk to patients about recurrence?
It's a matter of dealing with uncertainty, as Carly's eloquently put it, and I think sometimes the fear is greater than what it actually is, and sometimes we find people who really struggle to learn how to live with the idea that the cancer could come back and ruin everything. But I think overall it's a matter of just trying to say to yourself, I've done my very best to beat this, and you can't do any better than your best in this life. And if anyone was to quote me on anything, that would probably be it. Guess for a start, we probably should look at what we mean by recurrence of breast cancer following diagnosis. And there are four main types that are often described and sometimes lumped together in some of the studies that have been done. I think local recurrence is basically any recurrence within residual breast or a reconstruction. Regional recurrence is basically disease involving lymph nodes or soft tissue in the armpit or the supraclavicular that's above the collarbone area there. Distant is exactly what it means. It spread to other sites in the body, and that's probably the form of recurrence that we fear the most. It's generally not considered to be curable. We can control it. There are treatments we can use to stay on top of it, but we can't promise to be able to eliminate all the disease in that sort of situation. We sometimes also find in studies that they tend to include new breast cancers, a contralateral breast cancer, for example, in recurrence figures, which can be a little bit misleading. I guess in terms of understanding the level of risk, something we tend to do with early breast cancer as oncologists, just trying to give people an idea of what they face and what sort of treatments we should bring to bear to minimise that risk. So the size of the original breast cancer, whether lymph nodes are involved, we can use genetic platforms, just doing genotyping on tissue from the laboratory to determine whether the cancer has what would appear to be a high risk or not. And we really select our treatments based on all of this information to try and reduce the risk of future recurrence as much as possible. But one thing I guess I have to emphasise is that there's no scan or blood test that we can use to tell people whether there are microscopic cells present at the time of diagnosis or not. And it's a hard thing to get your head around, but one day we'll have a Star Trek scan or some sort of fabulous blood test that'll tell us once and for all and whether people need treatment or not. But I'm afraid we don't have that just as yet. I think the next slide, I keep telling people I've made the font smaller so I can try and squeeze all the scary stuff into one slide and move on as fast as possible. But first thing is that the initial therapy that we give may be entirely curative. In other words, people, if they've had surgery for their breast cancer, that may have been enough to control everything right from the word go. And all the other treatment is there for show or just as a safety net. We often use 5 years to describe treatments, but there's nothing magic about 5 years in terms of survival. It's lovely to be disease-free at 5 years, but it doesn't mean that someone is cured if they reach that 5-year mark without any disease recurrence. And just basically leading on from what I was talking about with staging scans, while we're heading along the track, our blood tests and scans can't tell us if there's anything lurking in the background. So, emphasising that adjuvant and neoadjuvant treatment, in other words, treatment sometimes given before or after surgery, things like chemotherapy, hormone treatment, radiation, is there to reduce that risk as much as we possibly can. So, if you had breast cancer, what can I do? What are the sorts of things that we can do to reduce recurrence and just try and maintain that feeling that we're doing everything possible, doing our best in the face of the uncertainty. First thing I'd emphasise is we want people to take their prescribed medicine. Sometimes people can't take medicine because of side effects. Sometimes we have to change. Sometimes we have to give people rests or breaks from their medicine. But trying to keep going with it as regularly as possible is a very important factor in the whole thing. There are also lifestyle factors that are difficult for us to study and be dogmatic about, but I think may have a lot of relevance in terms of helping people prevent recurrence in the future. And the things I've noted down there are exercise, weight control, diet, supplementary treatments, alcohol, smoking, and elimination thereof, and stress reduction. These are often the things that I'm asked about most commonly in this sort of setting. Probably the biggest impact that we've been able to find from any sort of study is with exercise. And earlier this year, or late last year, there was a big meta-analysis, a great big pooled collection of studies looking at people who had done some form of exercise versus little or no exercise. And as mentioned in the slide there are over 120,000 women who were looked at in this meta-analysis. And basically it came out of the wash that people doing in the order of 150 minutes a week of relatively light exercise, something like brisk walking, seem to have much better outcomes. And in fact, the study talked about a 40% reduction in recurrence over the follow-up period of 4 to 12 years. Now, this is all questionnaire-based. It's not what we call a prospective study, where people have exercise programs and then followed over time to see how things transpire, and that would be the ultimate answer. But it would appear that exercise has a beneficial effect, and perhaps the more exercise the better. There seems to be what they call an inverse dose relationship, with people doing more exercise and having less recurrence. Now, with observational studies, you're relying on people telling the truth. If someone asked me what I did in the way of my exercise, I'd lie through my teeth. And that's just me. And I think there might be a few around who are slobs at heart who don't want to own up to it. The other thing that is talked about a lot with breast cancer and is quite difficult and often a confounding factor with all sorts of studies is weight control. And we know that people, if they put on weight, time of diagnosis or even during treatment, if their weight goes up by more than 10% of their baseline weight, then that can impact negatively on their outcomes. And we've also had a strong sort of feeling from various observational studies that women who are overweight at the time of diagnosis may do less well. But we're not really sure whether active weight loss actually protects people, whether it has a preventative effect. And if you're looking at weight as the main factor, there are other things like general health and exercise and perhaps diet and other things that may confound that sort of outcome. So if someone is overweight or over their target weight and they're diagnosed with breast cancer, it's not a given that you're going to end up with recurrence. The relationship isn't that strong. But I guess from our perspective, I think trying to control weight is an important factor in terms of general health and prevention of possible breast cancer recurrence. One of the interesting things is scientifically, when we look at studies overall with diet, is that it's very hard to prove that a particular diet actually can prevent recurrence. And there's a lot said and written about diet and health and breast cancer. But when we do observational studies with the so-called Western diet, which is really high in processed grains and processed meats and red meats, versus what we'd call a healthy diet, rich in fruit and vegetables, whole grains, lean meat, chicken, that sort of thing, it's very hard to prove that you actually get a reduction in breast cancer mortality or recurrence, which goes against a lot of what we would intuitively think. But it is a very difficult area to study because it's hard to go and tell someone to eat a particular diet for 5 or 6 years, and we'll follow them for another 5 or 6 years beyond that, and all you rest, you can go away and eat whatever you like, and if you try and change diets, we'll shoot you, sort of thing. You can't actually physically do that. So we're often comparing groups of people with all sorts of confounding factors, and sometimes the results that we might think are there just are confounded and just don't come out in the wash. Often people have got concerns about particular foods like soy. I think a few years ago there was a concern that there were molecules within soy products that looked very much like estrogen, and these so-called phytoestrogens, plant-related estrogens, could have a negative effect as far as breast cancer was concerned. But in studies looking at soy, we've not been able to prove that people do badly with it. In fact, some studies actually suggest that people do better. And there are other molecules like isoflavones, which goodness knows what they look like or what exactly they do, but there's some suggestion that these particular molecules may actually have a protective effect. So in general terms, I would never tell someone these days that soy is bad for their breast cancer. So when we look at the scientific evidence, there's no robust evidence to establish one dietary pattern over another, strange as it may seem. Next slide talks about the vices, and there are all sorts of vices, but alcohol consumption is one of the things that we're worried about with breast cancer, especially development of a new breast cancer. But again, when we look at studies that have been done with alcohol consumption, it's hard to prove a link between alcohol and breast cancer recurrence once a diagnosis has been made. But because of that initial slightly higher risk of breast cancer development with alcohol consumption, we tend to say to people that they should limit alcohol consumption, at least to 1 unit per day at most. And a unit means a standard glass, say a wine glass or a standard beer glass with the appropriate alcohol. You can't have a beer glass full of wine or whiskey. Smoking cessation in one large study did come out with an indication that perhaps continuing to smoke after a diagnosis of breast cancer can be deleterious. But the risk pales into insignificance with the risk for respiratory cancers, cancers of the lungs, the throat, the bladder, that sort of thing. So not smoking is a really good idea, quite apart from breast cancer. Supplements are another really interesting area and very intriguing and very frustrating, because very rarely have we done these controlled randomized studies that alluded to at the beginning of the talk. A lot of people believe strongly in vitamin C, and really it's one of those things where I'd love to see a big study done with people getting vitamin C supplements in addition to all the other factors controlled, and just seeing once and for all whether there is a benefit. And I'm not sure there's enough evidence for me as an oncologist to thump the table and say that people must have vitamin C. Vitamin D is another interesting area where for a long time we've known that if you look at vitamin D serum levels in people with breast cancer and other cancers, they're often a bit lower than the general population. But again, we don't have good interventional evidence to say that supplementing that vitamin D on a prospective basis actually protects people. So it's another one of these murky, difficult areas. Use vitamin D to help control or help with bone mineral density maintenance when we're using treatments that might undermine bone mineral density and strength. But the vitamin D is not being used as an actual anti-cancer treatment. I'm also asked a lot about stress reduction, and generally I think difficult area to study once again. What's stressful for one person may not be stressful for another. Difficult to really get a handle on, but if you can tell me how to get rid of stress in your life entirely, let me know, because I'd love to know. And I also find people getting stressed about being stressed because they worry about what stress might do to them, and I think sometimes that can have a very circular, damaging sort of effect on quality of life. So I think really going with the flow and just coping with stress as it comes along is probably the best trick. So what would I recommend for my wife if we're talking about preventing recurrence of breast cancer? She's got to take her medicine regularly. Usually, I think most of us have got an idea of what our target weight should be. BMIs and other constructs can give a slightly distorted idea of what the perfect weight should be. Most of us have got a good feel for what our weight should usually be and what we're comfortable with, and that's what we should aim for as far as I'm concerned. Walking 30 minutes a working day at least to give you 150 minutes of walking. Has to be brisk walking, not walking my dog, sort of stopping at every lamppost. You have to really get that heart rate up, and just a good brisk walk. But just 30 minutes a day I think is doable for most of us. Everything in moderation as far as diet is concerned. No smoking, no alcohol. Well, not no alcohol, one unit a day at most. So a bit of leeway there. Vitamin C, one unit a day at most. So a bit of leeway there. Vitamin C, vitamin D, multivitamin supplements, I believe, are optional at the moment. I don't think there's a strong case for, and definitely not against. Live life to the full is what I would say as well. Try not to look over your shoulder, as Carly talked about, more than you need to. It's natural to look over the shoulder from time to time, but life's forward rather than back. And you're not alone. Lifestyle recommendations that have come out of the wash are the sorts of things that most of us should be doing anyway. And you can involve your family or friends and other idiots who need to improve their health overall. So really it's not something you should be doing in isolation by yourself. And if you are in a situation where you have any indications of something niggling away, if it's disproportionate, Carly talked about being worried about things that she might not usually be concerned about. But if you've got something that is niggling away for 2 or 3 weeks, even if it's not particularly severe, no good reason for it, it's disproportionate to what you'd expect to have, then I don't think you need to hold back from talking to your doctor or your specialist about that. It's better to clear the air rather than have something weighing on your shoulders in this life. I thought that's all I'd bore you with.
Well, thanks, Mike. That was actually super helpful. Good morning. Our last speaker is Dr. Geraldine Tennant, a health psychologist who specialises in breast cancer and extensive experience, counselling women through emotional and physical challenges during and after treatment. Geraldine works as a breast cancer oncologist at Auckland City Hospital, so some of you may have met her, and also in private practice. So Geraldine, what have you got for us?
Thanks, Adele, and thanks very much for the opportunity to come and speak tonight to the Breast Cancer Foundation. I think these webinars are extremely important and make a lot of information more accessible. I think fear of recurrence is a very common issue that I work with in my clinical practice. And I think it's important to say that for some women that fear of recurrence starts right from the time of diagnosis. So as they're going through active treatment, there's fears percolating, ruminating around that this cancer is going to come back even though I'm having treatment that's curing it. But typically I would see women often as they near the end of their treatment, or indeed sometimes a year, 2 years post-treatment, where that fear of the cancer coming back is the primary drive often to seek extra counselling support. So we do know that for the majority of women, fear of recurrence reduces over time. So time is a great healer, but for others it's a really great concern. So when I talk about the impact of it on psychological well-being, that can mean it's coupled with anxiety, low mood, impacts on a woman's quality of life, so it's often hard to think about the future, to plan for the future, even to book that holiday because they're so worried that the cancer will come back and thinking about the impact that it will have on their lives. I've got a point there just even thinking about cost issues, so we can think about the psychological burden that women experience with fear of recurrence, but also cost issues in terms of greater use of health services. So often women are experiencing a symptom that they see their doctor straight away to get it investigated, or conversely some women, because they're so fearful of what may be discovered, actually avoid seeking medical help. So it's sort of a double-edged sword when that fear of recurrence is at play. So my role is often to normalise the fear and also to validate their feelings. But there's certainly some strategies and ways of thinking and coping that I can support women around their fear of recurrence. So my next slide details some specific fears, because I think it can be helpful to think of fear of recurrence as more as an umbrella term for specific fears. And I've got some listed there. Probably two of the most common ones would be the fear about actually having to go through treatment again. So a woman who's completed all her treatment, and often the biggest fear is maybe having to consider chemotherapy again. And also planning for the future. So often it's, what is the point? The cancer may come back. How can I even make small-term goals, let alone long-term goals? Also, what's really important to think about is the sort of triggers for the fear of recurrence. So it's often heightened at particular times. So that can often be a common one is the first mammogram women have post the mammogram they had when they were diagnosed. There may be particular anniversaries, there's a trigger, so it might be when they're thinking about when they've finished treatment, or indeed the date that they got the diagnosis. Often the trigger is someone else's cancer story, and that's not often quite an unhelpful story. So sometimes even having boundaries around, I think as Carly eloquently said, just thinking about it's your health, it's your story, your experience. It's not always helpful listening to other people's journey or experience. An experience of a physical symptom is often a trigger for worrying that the cancer's come back. Sometimes illness in another family member, or indeed if you're feeling particularly stressed or fatigue. And fatigue is such a common experience for many women, often months after treatment. So we know that fear of recurrence is very common and normal in the sort of adjustment post-treatment. How can you actually cope with this fear? Well, I think what I talk about with women is a shift from a sort of illness way of being in the world to a wellness model. So it's thinking about your own self-care. A first port of call can actually be thinking about this idea of talking to your trusted health professionals, actually getting some answers to your questions. And sometimes women will say to me, I'm not sure I always feel brave enough to get that, but getting those percentages sometimes, or talking through the things that they can do to look after themselves. So shifting to the idea of wellness is thinking about your own self-care. What do you enjoy? And they may be very different things now that you've come through your breast cancer treatment. What actually matters to you, and doing more of those things that you enjoy. Maybe learning some new skills like relaxation, meditation and mindfulness. Often women have used those sorts of skills or developed those skills through their treatment, but very helpful sort of in the post-treatment phase to help with fear of recurrence. Attending follow-up appointments, getting those questions answered, which may sort of reduce a lot of the fear, and making some of those lifestyle changes which Mike has already talked about. So reducing stress, and that can be using some of those strategies like relaxation, meditation, limiting alcohol, and doing some exercise. So again, just thinking about a shift to a focus on wellness to help manage your fear of recurrence. Next slide is thinking about, well, when should I actually consider getting extra support? I'm doing a lot of these things, but I'm actually overwhelmed with fear. It's stopping me making plans. It's stopping me doing the things that I enjoy. So essentially, often women will say to me, Geraldine, I feel quite stuck. What do I do? And that may be the time to actually consider getting some extra support through about who can help. That first protocol may be your GP, and they can refer you into the various cancer services around the country, even accessing things like the free counselling service that the Breast Cancer Foundation offers. Conversations with your medical oncologist, your nurse specialist, psychologist or counsellor. And what can be very powerful, often post-treatment, some women have said, I didn't feel like joining a support group or talking to other women as I went through treatment, but I'd really like to now. So often talking to other women about how they've managed different fears. Are they actually experiencing fear of recurrence? And often that's a normalising process to get that out there in the open and talk to other women and realise that you're all experiencing that sort of feeling. Then thinking about if you're a partner, family member or friend watching this evening, someone who's gone through breast cancer treatment or going through breast cancer treatment, how can you actually help them? Well, a really good starting point, I think, is to actually let them talk about their fears. So often women say that, everyone thinks I should be jumping up and down. I've finished treatment. And I'm almost a bit scared to say I am still frightened. I am fearful about the cancer coming back. So for you as that partner, family member, or friend, to have that awareness that this significant person in your life may find it helpful to talk to you about their fears, and that you can actually simply listen. It's a very, very powerful thing to do. You don't have to find a solution. And it may be actually helpful that you say to them, remember there are other people you can talk to in a kind of professional setting for extra counselling, but also thinking about practical ways you could support them. Let's do that regular walk together, because I know that exercise is a big part of your wellness plan. What can we actually work on together to reduce your fear and worry? It's really helpful that the person feels heard, and potentially reminding them that help is available. If you are referred or wanted to see someone like me or a counsellor or someone working in this area, there are different strategies we can work on. So thinking about different types of therapies like cognitive behavioural therapies, and looking at some of the ways that you're thinking, aspects of acceptance commitment therapy, and using mindfulness. These are all strategies that are incredibly beneficial as you're going through treatment and in the post-treatment phase, where we typically see a lot of women experiencing that fear of recurrence.
Great, thank you, Geraldine. And just tell me, Geraldine, are you registered in our counselling?
Yes, I am.
Yes,
so yeah,
I'm registered. So some of you may know we do offer free counselling to anyone who has breast cancer, and you can choose the counsellor or psychologist that you see from an approved list, and Geraldine is on the list, so you're welcome to get in touch with our nurses and get a referral for that counselling if you like. Okay, thank you so much, all three of you. We're now going to open up to some questions from you guys at home. You can type questions in the box at the bottom left of your screen, and we'll get through hopefully all of them in the time that we have left. We've got plenty of time, so that's good news. Now, I've got a couple of questions here. Mike, you seem to be our resident dietitian tonight. What's your view on the effects of foods high in antioxidants or superfoods?
I don't think there's enough evidence to really say that they're a must, but what I would say is if you wanted to incorporate them into your diet and enjoyed eating them, that's great. If they tasted disgusting and really you dreaded going anywhere near them, then I don't think they're the sort of thing that I'd push anyone into having. How's that sitting on the fence? I think it's interesting with antioxidant type of foods and supplements and things that some oncologists worry about using those sorts of foods during chemotherapy, because a lot of chemotherapy drugs generate free radicals that help damage cancer cells. And the feeling is that if you're using antioxidants, they may mop up some of those free radicals and maybe get in the way of the chemotherapy. I don't think there's any hard evidence for that personally. You'd have to speak to your own medical oncologist if you were getting chemotherapy. Just to clarify that, the people under my care, I'm quite happy for them to consume antioxidants and so-called superfoods during chemotherapy.
And Mike, is that the same theory about vitamin C during chemotherapy? I think there's really, I think there is a worry about it tripping over chemotherapy, and I guess I must admit, when I've looked at people taking high-dose vitamin C over a gram or more IV during chemotherapy, I've sometimes found their white cell counts, their neutrophil counts, can be a little bit lower than I would expect. And if that's happened, I've actually asked people to stop their vitamin C. Now, people who give vitamin C say, look, there's no published evidence about that at all. But I think as we're going along with treatment concurrent with chemotherapy, if something isn't quite right, then sometimes we just have to pare things away and just try and keep things simple. In general terms, something like vitamin C is unlikely to cause any harm that I can see. But if practically there is some sort of issue, then we have to really think twice. And then pick it up later after the chemo is finished and so on. Great.
You didn't have vitamin C, did you?
Not during.
No.
Are there any exercises to help with anxiety?
I think generally exercise helps overall for both mood and anxiety, so I can't say specific ones, but in terms of some of the evidence Mike was talking about in our recent conference I attended, there was a number of key presentations around the value of exercise, and walking was a big one, doing weight bearing as well, because that obviously has links to benefits for bone density. So the exercise didn't have to be running half marathons, sort of good brisk walking and some weight bearing exercises are very beneficial.
Surprising how little exercise apparently is required for benefit. So it's, I think like Geraldine, I'd sort of pictured very heavy-duty stuff as perhaps the answer, but it's just 30 minutes of walking 5 times a day per week, and it's a good quota of exercise overall from breast cancer reduction side of things. And I guess some exercises you just end up in a vaguely happy place.
Yeah.
If it's running, I'm definitely not happy. But I think swimming, walking, those sorts of things. It's for me personally, I think they're great stress relief.
Yeah, and finding exercise that you enjoy as well. That can be linked to reducing anxiety and increasing mood. Yeah.
And actually, that's sort of almost in the exercise camp. We're going to be posting an article soon about a study around group singing and for breast cancer or cancer patients, and the reduction in anxiety that can result in. At Christmas time, Susan seems like a good thing to consider doing a bit of carol singing.
If you're asking me for it here and now, that was
my Okay. Now, there are questions about the chemotherapy causing secondary cancers. What are the percentages of this?
Very, very low. In the old days, when we used to use very high doses of cyclophosphamide and anthracycline drugs like doxorubicin, often well beyond thresholds for longer periods of time. You can see 1 in about 5,000 people developing a secondary cancer like leukemia. Most of our modern regimens, we actually have limited exposure to those sorts of drugs. So people get exposed in bursts rather than a prolonged exposure. So the risks are even lower. So I think these days we can't say there's no risk of a second malignancy, but it's tiny. It's be less than 0.1%. Very, very small.
Is there a case to say that weight doesn't matter as long as you're getting your heart rate up?
Yeah, that's a really hard question to answer, because I think there are some people who are just heavy, full stop, and they may be fitter than me. You know, you look at an all-black prop who might, on BMI, might be obese, but they're 300 times fitter than I am. And I think overall, if you've got a target weight, you can work towards that potentially. But exercise is probably the most important thing that you personally can do in my book. I think that's with the limited sort of information that we've got about lifestyle factors. Exercise, I think, falls out of the wash with the strongest sort of effect. And weight can be just the most frustrating thing on the planet trying to shed. And whereas exercise is something you can get out and actually do and own, as it were. So I'd like to think exercise does trump weight, but it's hard to actually be scientific about it and say that's definitely true. But I'd concentrate on the exercise personally.
And we have a question from a runner here, which I suspect we can't answer, saying she runs an hour a day. Is that even better than?
Probably is. Yeah, there is what they call, I mentioned while I was raving about exercise, there is an inverse dose relationship with exercise, so that studies showing people doing more exercise, more intense exercise, seem to have proportionately lower rates of breast cancer recurrence. And I think people who are fitter, perhaps are better in all aspects of health, I suspect. But I wouldn't ask someone to totally exhaust themselves with exercise in the hope they're squeezing every single last bit of protection out of things. It's exercise that suits you and you are happy with and you can cope with. So I congratulate you for running an hour more than I run a day. It's what you're happiest with, I think. The minimum, I guess, from the studies is walking 30 minutes, 5 days a week.
Now, a question about how many counselling sessions someone can get. It's at our Breast Cancer Foundation Counselling. We offer 3 free sessions, but then we would, if you needed more than that, we would certainly be willing to talk about that and consider more. Geraldine, the DHB's District Health Boards offer free counselling?
Yes, so within the breast service at Auckland City Hospital where I'm based, it's free.
Yep.
And there is no sort of limit as such. I mean, a lot of my work is around early diagnosis time, so sometimes it's 1 or 2 sessions at the initial stages, and then women tap into me often as they go along through treatment, or sometimes I'll see women right at the beginning and then it's sometimes a year after, so there's flexibility around that, whereas some people need sort of more regular support.
Yeah. Yes, and we find the same, that we offer the counselling at any stage after treatment, because we don't know when we're going to need it.
Yeah.
So I guess if you check with your specialist and they can tell you what's available through your local hospital if you're not in Auckland or if you're not in an Auckland hospital, and certainly your GP can refer you, I think, to Cancer Society. See what else we've got here. I had triple negative breast cancer last year, finished chemo and radiation in November. I was surprised there were no final MRI or CT scans to check the treatment worked. Are patients able to request a final test or scan to ease their mind a bit when treatment ends?
sometimes we'll do a sort of an exit scan after treatment if there was something at staging that we want to follow and check on. For most people, though, there's actually nothing that we can measure from the outset. And if we get a negative scan, we can't see anything. It's lovely, I guess, but it doesn't tell us for certain there's no cancer there that could play up in the future. And it's a hard thing to really rationalise, but at the moment our tools aren't good enough to give us absolute reassurance that there's no cancer there. And sometimes we can get caught in a negative situation where we do a scan just to try and reassure someone, and then we find some little dot somewhere. And often what we find then is it's too small to biopsy, and we have to follow someone with a short interval scan to see if that dot is growing or changing in the way of a spot of cancer. Often, one particular case I can remember recently when we did that, that dot had gone, but there was another dot somewhere else on the follow-up scan, and you can end up on a treadmill, which isn't particularly helpful. So, as strange as it may seem, scans in that sort of situation don't help us an awful lot. If we've got symptoms or problems that suggest there could be a problem, then a scan or appropriate tests are the sorts of things we should be doing. But scan for the sake of a scan is something we try and avoid overall. Have a word to your oncologist or your specialist, but I think you'll get a spiel a bit like mine.
I've had several people ask me about sugar and cancer, and I guess we quite often hear this line, sugar feeds cancer. What's the science behind that?
Well, I think cancer cells are more metabolically active often than normal tissue cells, with the exception of places like the bone marrow and the gut mucosa and that sort of thing. But you can starve the body of sugar and it'll find it from other sources. You'll break down protein and other things. The brain and nerve cells run almost exclusively on sugar. So limiting sugar intake is not something that I would personally say is likely to hit cancer cells exclusively. So there's a lot in the community about low sugar diets, ketogenic diets, that sort of thing. But look, I don't really personally subscribe to them. I don't think you're putting yourself further ahead by doing that.
Okay, question. My GP missed my breast cancer if she couldn't feel a lump. The cancer was scattered all through the breast, and it maybe sounds like a lot of the cancer. She was going by Health Pathways guidelines, and we may not be familiar enough about them having them in front of us. They feel that GPs are not well enough informed by the guidelines. They feel that GPs are not well enough informed by the guidelines, I guess, about cancers that they can't necessarily feel.
Sometimes specialists, very experienced doctors can miss primary breast cancers as well. It sometimes happens, unfortunately. And one of the hardest types of cancers to pick up is this multifocal, small volume disease. Lobular carcinomas are famous for avoiding detection too, because they tend to have a strandy infiltrative growth pattern rather than forming solid lumps. So, I think most GPs these days are very, very adept at detecting lumps clinically in the breast. But it doesn't matter how good the doctor is from time to time. Unfortunately, there can be misses. I'd love to say that there were never any misses, but there are, and I'm sorry you've been one of those. But I think one of the reasons for mammographic screening in the population is to try and make sure that we pick up the lesions that we can't necessarily feel to the best of our ability. But even with the very best mammograms and the very best doctors interpreting those mammograms, there still can be misses. So if someone's had a mammogram and they've been told it's clear but they can feel a lump, or they're worried about their breast, there's a change in the breast, it's still very important that it's again checked out. So unfortunately, we're not foolproof in terms of detecting these things up front.
And I guess as a foundation, we would say to people that if you're not satisfied with what you've been told and you do really feel you need further investigation, then keep pushing for that. Now I see that one of the earlier questions I only had missed a line out of the middle of it, and I've got the proper question through now, which was about it's not about weight, it's about weight training. versus aerobic exercise, is there a case for weight training over aerobic exercise or vice versa?
I think from the stuff I've read, and I find that the assessments of exercise intensity a bit confusing, but I think a mixture of aerobic and weight-bearing exercise is probably the best. Talked about that walking for 150 minutes a week as being minimum, but if someone's doing intensive exercise with quite extensive gym work or running, sometimes 75 minutes with weight-bearing exercise added to that at least twice a week is often described as minimum in that sort of situation. And that's the sort of level of exercise that the American Cancer Society recommend. So I think if again, that particular type of exercise was the sort of exercise that you preferred, I think that's still great, but I'd probably mix it with a bit of aerobic exercise as well.
Now here's one from someone, I'm not that worried about recurrence, but my family is, and they're worrying me. Geraldine, have you got something to say?
And that would be an important conversation or conversations to have around sort of containing, and even maybe kindly saying to them that they could get some support that's separate, so you're not taking the burden of what's going on for them. So certainly there is support available for often the term caregivers, but by that we mean partners, other family members of the woman who's got undergone breast cancer treatment. So that can be around maybe suggesting they get some coping strategies through extra support, that acknowledging what they're experiencing, but it's okay to set sort of some boundaries and containment around those ongoing conversations. And you can frame that or talk about that as, as part of your wellness idea or plan going forward, and it's not something you want to keep talking about. And often women will say that even, and I think you've sort of alluded to that a bit, Kylie, about not wanting to revisit the diagnosis story or go back or I've got through treatment and it's not helpful for me to keep talking about that. And then obviously with family members moving into being fearful about the cancer coming back, I mean, that is a really real emotion that, thinking about is that helpful for us to keep talking about it, not for you. So, yeah, thinking through some coping strategies for that family member or the family members, I think it's helpful.
Yeah, I think, I often think that these situations, I mean, you yourself might be the patient going through on this journey, but it doesn't mean it hasn't affected those around you, and so everyone is on a bit of a journey themselves, and being open and recognising that those are perfectly valid feelings for them to have, and you've got a role to play in your relationship with them and listening to them in the right, if you can, in the right way as well within the bit. Yeah. But no, I definitely I hear that person's perspective.
Do people who've had a double mastectomy need to have mammograms?
No. If they've had bilateral mastectomies, you haven't got much breast tissue to actually squash, and the mammogram plates there. So bilateral mastectomy you let off.
But I guess while we're on that subject, we would say that one of the best things you can do to check for recurrence is to get back into the mammogram program, and you should be having mammograms through the breast clinic at your hospital, I think annually for 5 years, and then actually you often won't be recalled by Breast Screen Aotearoa. Depending on the region, they don't necessarily have a recall program to get you back into mammograms, so you need to re-register with Breast Screen. Sometimes if they're in the same place as the public hospital, then that will all work out fine, but if you haven't heard from them, you can go to them 1 year and then back to the hospital the next year, for at least another 5 years after that. So that's perhaps a reassuring way for people to get an easy check about local recurrence at least. Let's see, we're nearly done actually, we've got 1 more minute. I was told by a surgeon to drink red wine versus white wine because of the sugar levels in white wine. No? Don't give up your Chardonnay if that's your preference. And just really, I guess, there's a bit of frustration out there about this idea of no test to monitor. The ongoing checkups I have are just a feel of my glands. I never get a blood test or anything else. There's nothing else.
When I first came into oncology, we used to do regular blood tests for people on follow-up, and we actually used to do quite a few scans and things. I've talked about the scans, but the pick-up rate with our blood tests, what we can measure in the blood, is very limited. There is a protein, glycoprotein marker called CA15-3 that can be measured in the blood that is produced by breast cancer tissue, breast tissue and breast cancers as well. But again, it's not foolproof. It can be normal when there's plenty of mischief going on. It can be abnormal when there's nothing related to breast cancer. So it's just not sensitive and specific enough to rely on as a screen. So one day we'll be able to measure circulating tumour DNA, and I can understand people's frustrations, and Carly and I have talked about it quite a bit. It'd be lovely to be able to offer something to say, look, you are clear or absolutely zero indication of cancer there, but we don't have a tool that's that good at the moment.
Okay, well look, it's 8 o'clock, our time is up. Thank you for joining us tonight, and thanks again, huge thanks to Carly and Mike and Geraldine. You've all been fantastic. We hope you at home found this helpful, and we'd appreciate if you could take time to give your feedback as you exit the webinar. If you've got any questions that you really want to talk to someone tonight, our nurse Janice is available to take your calls. Her number will be on your screen, if you just make a note of that. Otherwise, tomorrow, she's around till 10 o'clock tonight, and otherwise you can call out 0800 BC Nurse line tomorrow or send an email to that address on the screen. The nurses can provide referrals to free counselling, as we talked about, and also funded rehabilitation after surgery. And we can also help you connect into MyBC, which is our online community for patients and their supporters. In the next few days, we'll send you a link to the recording of this webinar if you'd like to watch it again or recommend it to someone else. Thanks again for joining us. Good night.